As part of a breastfeeding course with BCIT, today we're going to discuss overcoming breastfeeding challenges. The topic under discussion will be inverted nipples with the preterm infant. In order to discuss this breastfeeding issue, we will be using a situated clinical decision-making framework. This involves knowledge, patient cues, judgment, decisions, and evaluation. So knowledge. Nipples come in all different shapes and sizes. While some nipples protrude and are easy for the infant to grasp, some nipple shapes make it difficult for the infant to nurse. For example, inverted nipples. Normally, the nipple reaches into the infant's mouth and stimulates the sucking reflex by touching the hard palate. When they're inverted, this stimulus is absent. An inverted nipple can be caused by short milk ducts or by tight bands of connective tissue that connect the center of the nipple to the breast. The level of inversion varies and often changes during the third trimester. The inverted nipple cannot protrude when stimulated, but it can be manually pulled out, or with severe inversion, the nipple responds to compression by disappearing completely. The degree to which inverted nipples affects feeding depends on the level of inversion as well as the infant. If the infant is able to latch and feed regularly, it might be able to loosen the adhesions. However, in the case of prematurity, nursing with inverted nipples could be really hard. Whether or not a premature baby can breastfeed will depend on its age as well as its health status. Many babies require more time and practice to be able to feed at the breast. Premature babies often lack the stamina to exclusively breastfeed and/or the skills necessary to coordinate suck, swallow, and breathe mechanisms. Therefore, infants who are too premature may require alternate feeding methods.
Hey everyone, Nurse Ashley here. Now that we've got a bit of understanding of the general knowledge behind our breastfeeding challenge, I'm going to talk to you guys about the cues and signs and symptoms associated with inverted nipples and the premature infant. I'll begin our discussion by explaining the inverted nipple. First and foremost, proper assessment should occur with the help of a healthcare professional. With an inverted nipple, the nipple is retracted into the breast instead of pointing outwards. The nurse can perform a simple pinch test to determine whether or not the nipple is truly inverted. To conduct the test, the mother or nurse holds onto the breast with their thumb and finger under the edge of the areola. You press in gently and firmly about an inch. Ideally, the nipple will protrude upon stimulation, but if inversion is present, the nipple will retract or disappear back into the breast. Other cues from the mother that may indicate a breastfeeding challenge include engorgement, decreased milk supply, or decreased maternal confidence. Having inverted nipples doesn't necessarily mean that breastfeeding will be impossible. However, it may pose as a significant breastfeeding challenge, especially when working with a preterm infant. A premature infant is any infant born prior to 37 weeks, while a late preterm infant is born with a gestational age between 34 and 36 and 6 weeks. The physiological symptoms of preterm infants vary significantly based on their age. However, the nurse can usually expect some degree of variation in functioning. In order to conduct an accurate assessment, the nurse should first determine the age as well as the overall health and physical anatomy. Depending on the age, infant feeding behaviors such as cueing, ability to latch, and ability to become satiated with feeds might be compromised. To determine whether or not the infant is receiving adequate nutrition, the nurse can assess the infant's weight and output, as well as the lab values. They can look at the bilirubin to see whether that might be affecting the infant's ability to feed adequately. The nurse should assess how these factors are affecting the feeding relationship as well between the new mother and the baby and the mother's attitudes about breastfeeding. Once the nurse evaluates the assessment findings in comparison to current research, he or she must question what's happening with mom. Due to her inverted nipples, the mother may be having difficulty expressing her breast milk or may find breastfeeding more painful. Also, we must consider that the preterm infant may have difficulty breastfeeding, and it is likely that the mother will not be expressing enough milk. This could lead to engorgement, plugged ducts, mastitis, and eventually a decrease in the overall milk production. As a result of the immature body systems, several things may be happening with the infant. Preterm infants often have increased nutrition and immunological needs. They are less able to regulate their own temperature, blood sugars, stress levels, and oxygenation, and are often more susceptible to jaundice. As a result of their immature neurological systems and low energy reserves, preterm infants are also at an increased risk for poor feeding habits. They often have immature feeding reflexes like rooting and latching, and have poor coordination of the suck, swallow, and breathe mechanisms. They do not always break regularly or spontaneously to feed, and they often tire easily at the breast. Tiring easily or quickly can often give a false impression of feed satisfaction. What do these challenges mean for the breastfeeding relationship? Well, being a new mom and adjusting to life with an infant can already be an overwhelming experience. Add inverted nipples and a preterm infant to the mix, and several other issues may arise. Depending on the situation, the mother may be experiencing extreme fatigue or sleep deprivation and/or a lack of confidence while caring for her preterm infant and their intense physiological needs. The mother may need to be pumping every 3 hours, 24 hours a day to provide the necessary express breast milk, and they may have a lack of support or increased feelings of worry, stress, or anxiety related to the uncertainties of their infant's health. The infant condition, possible incubation, and hospital practices and environment may also interfere with the ability of the mother to read and respond to infant cues and/or to develop the maternal-infant relationship. The nurse should also consider involvement of other healthcare professionals, such as a physician and/or a neonatologist or pediatrician, to manage the care of the preterm infant. A lactation consultant to support the mother in the challenges may be helpful because she might find it hard with her inverted nipples. And possibly a public health nurse or breastfeeding clinic might be able to provide ongoing support as the mother transitions into the home environment.
Although it might look slightly different with the preterm infant, there are 3 priorities when working with breastfeeding mothers. These are to feed the infant, to move the milk, and to help the diet learn to feed. Priority number 1, feed the infant. Ideally, this occurs at the mother's breast, however, this might not be possible with the preterm infant. If supplementation is necessary, substitutes include express breast milk, donor milk, or artificial milk. These can be given via dropper, spoon, cup, feeding tube, or bottle. Ultimately, the infant must be fed the appropriate amount in a reasonable amount of time. Priority number 2, move the milk. The breast must be emptied frequently and effectively in order for ample milk production to occur. Production is strongly based on supply and demand. Again, the mechanism to which this emptying occurs will depend on the maturity of the infant. Either the infant provides the means of breast emptying or expression of milk via hand or breast pump will be necessary. Priority number 3, helping the dyad learn to feed. This complex process depends on a variety of factors between the mother, infant, and environment. Priorities 1 and 2 must both be met before a successful breastfeeding relationship can be established.
The clinical decisions and associated learning needs will vary based on the infant's maturity and mother's level of understanding. In regards to feeding the infant, the parent should be assisted to make informed decisions about what, when, and how to feed their infant. Nurses may need to assist the parents in using different breastfeeding mechanisms appropriate with the infant's gestational age. This could include increasing the frequency or duration of feeds, assisting with the latch, encouraging skin to skin, stimulating the infant to maintain alertness, and/or suggesting breast compression during the feeds. Depending on choices made in regards to supplementation, the family may need assistance to provide EBM with pumping or hand expression, in accessing donor milk, or in choosing a type of formula. Ultimately, the nurse should always encourage the use of human milk for the preterm infant because human milk optimizes physical growth and can protect the infant from infection and illness to which they are more susceptible. Mothers with inverted nipples and preterm infants may require more specialized support to encourage the movement of milk. If the infant is breastfeeding, the same strategies can be used to assist with the breastfeeding mechanisms, such as frequent feeding, assistance into skin, and infant stimulation. However, extra assistance may be required due to the nipple inversion. In order to establish that good latch, several techniques can be used, such as nipple stimulation prior to feeding, and breast shaping or the manipulation of the nipple to help it protrude out more. If these techniques don't work, the use of a nipple shield or a suction device or even a breast pump may be helpful to protrude that nipple, although these techniques are not strongly supported by research. In the event that the infant is unable to breastfeed at all due to immaturity, the mother should be assisted and encouraged to hand express her milk and/or to pump regularly. They should be taught to hand express or pump as much as the infant would normally feed, so about 8 times in 24 hours. This can be done either exclusively or after feeding the infant if the infant isn't feeding adequately. Skin-to-skin contact, warm compresses, gentle breast massage, and relaxation can also promote the letdown of milk. Helping the dyad learn to feed is a complex and ongoing process. This process involves the entire family and their participation in getting to know their new baby. This means that we must work to include them in all aspects of care, including feeding, diaper changes, and lots of skin-to-skin. The mother needs to be reassured that her breastfeeding efforts are not going unnoticed, that she's supported, and that she's doing a great job, regardless of the individualized circumstances. With time, helping the dyad learn to feed is a challenge that can be overcome, and lots of skin to skin is essential to create that mother-infant bond, especially in the early stages of breastfeeding or if they're not breastfeeding at all.
The last step in our decision-making framework is to evaluate the outcomes of our clinical decisions. Were our interventions successful? Is the mother satisfied with the breastfeeding relationship? And most importantly, have our 3 priorities been met? Ongoing evaluation allows for effective care planning and ensuring that patient needs are met. Thanks for watching, everyone!